everyone. Welcome to this month's Autism 200 lecture series. Usually my colleague Jim Mancini welcomes everyone and does introductions. I am not Jim Mancini. He is in San Diego having a nice vacation, so I'm covering for him. I'm Jen Gertz. I am a psychologist at the Autism Center, and I am delighted to introduce Molly Savasco, who's our speaker for today. She will be talking, her talk will be on recognizing and treating trauma-related symptoms in children and adolescents with autism spectrum disorder. Molly did her graduate training at the University of Washington right here, and then went down to Children's Hospital in Los Angeles to do her clinical psychology internship, and then did additional training up back in Northern California at University of California, Davis, at a community mental health clinic there for her postdoc training. And Molly has a passion for community-based mental health and autism, and has been committed to infusing trauma-informed care with our population. And so we're very excited to have her. We're honored to have her at the Autism Center, and looking forward to hearing her talk.
Hi, hello. That's so nice. You said hi back. Thank you. I just want to make sure that you can see the slides. Sorry, I'm really not tech savvy at all. This is where I send up like an SOS. I need help from a grown-up. Oh. I had to press a button. Hello, my name is Dr. Molly Savasco, and Jen is absolutely right. I am a psychologist here at Children's. I work in the Autism Center, where I really like to specialize in talking about trauma and trauma-related symptoms, especially for people with intellectual and developmental disabilities. I am really interested in this population because I think, as most of you would probably already acknowledge, this is an underserved and under-recognized issue, which is really interesting because one of the things we'll talk about today is how much higher the rate of abuse is for people with disabilities than it is for typically developing kids. And I want to spend some time talking about that in a little while, but I thought first I would just jump in with a little bit of an introduction. So I have to tell you, I'm wearing this like headset that's, they called it the Britney headset. Like Britney Spears would wear it, and I have this lifelong belief that I was supposed to be Lady Gaga, and this is just totally feeding into it. So I am just so thrilled right now. I can't tell you how excited I am. Please don't tell my boss that I'm saying these things to you. Okay, anyway, so who am I and how did I get here? Like Jen said, I did my graduate work at UW and then went down to Children's Hospital Los Angeles, which is a really fabulous place to be. The training program there is one of the university centers in excellence in developmental disabilities. So they really have a passion for serving folks with all different kinds of needs, and I specialized in the trauma track there. One of the best parts about being there was that I did bilingual work, and it's a real important reminder that trauma can look different in different populations and even in different regions, right? So a lot of the families I worked with there were really dealing with immigration trauma, which is a very real thing. Whereas in different places that I've worked, that population looks really different. So very eye-opening for me, and really just cemented that community mental health and providing access to populations that historically have been underserved is really where I want to spend my time. I think that everyone could benefit from having someone to talk to, and sometimes it's awfully hard to find the right person. So I'm just really interested in trying to make sure that kids who maybe historically we haven't thought about needing therapy services or benefiting from therapy services have the opportunity to make that decision for themselves. One quick thing I just want to say in terms of language, I do use person-first language. I'll say that that's where I'm most comfortable, and I recognize that that's not where everyone is comfortable, and I appreciate your flexibility with me in making that decision. All right, so just real quickly, I do want to say this is a topic that brings up a lot of different emotions for people. You might feel really angry thinking about this. You might feel really sad. You might be really overjoyed to be talking about it. There is no wrong emotion to feel here, and there's also no wrong reaction to have. I think sometimes we just tell people you can get up and take a break if you need to, and I'm not actually here to tell you what you need to feel okay in this presentation. If what you need is to stay here and zone out for a minute, totally cool with me. I don't call on people randomly, so don't worry about that part. You stay engaged the way that it works for you. Fair enough? Okay. People on Facebook, you are welcome to do some shoe shopping if you need to. That's what I tend to do for distress tolerance. Okay, so just a little bit about you. I'm going to ask folks in the room first. If you feel comfortable raising your hand, totally fine if not. In terms of who we have here, do we have caregivers today? Okay, a couple of caregivers, welcome. Do we have providers or clinicians in the room? Hello, hello. Do we have any self-advocates here today? Cool, welcome. Anybody that I missed that you want to make sure we know you're here?
Grandparents.
Parents?
Grandparents.
Oh, grandparents, totally. Sorry, I thought I covered that in caregivers, but you're absolutely right. Grandparents have kind of a very special role, huh? So thanks, thanks for being here. On Facebook, I don't know how I'm going to know who you are, but if you're a provider, a caregiver, a self-advocate, if you have another role, if you're a teacher, welcome and thanks for being here. It's awesome that you're tuning in. Okay, I'm getting the nod that there might be people on Facebook. That's great. Good. Okay, so I want to talk about my objectives for tonight's presentation. I want you to know where we're going. So I want to make sure that you learn about the prevalence of potentially traumatic experiences in our IDD population. I do want to point out it's potentially traumatic experiences. It is not my job to tell you what's traumatic and what's not. That's for you to decide. It's my job to help you heal, if that's what you're looking for. Not tonight, but if I was your therapist, that's what I'd be working on. I want to talk about diagnostic criteria for trauma-related disorders in kids, and I want to think about that too within the context of folks with developmental disabilities, because I do think we need to rethink as providers how we're qualifying kids with diagnoses. I do want to talk about common misconceptions about trauma in the IDD population, because I think there are some heavy ones that float around that really impact how we as providers try to provide care. I'm also going to talk briefly, if there are providers online, and I know that we have some in the room, talk about some trauma-informed care strategies and thinking about what kind of messages we send to clients or potential clients in the way that we act and talk with them. And then I want to just touch on treatment approaches and steps for trying to enhance safety. When we get there, one thing that I do just really want to point out is when we talk about enhancing safety, I think that there is a real potential, if something has happened to you in the past, there's a real potential to feel blame that you didn't do those things the first time that something happened. When I talk about enhancing safety, I'm just purely talking about steps that are good for anyone to think about within any context, okay? You didn't do anything wrong if you didn't do these things when something happened. Fair enough? Okay. So let's talk about how we define trauma. This is from the National Child Traumatic Stress Network. This is a fabulous resource that I would really encourage you to check out if you're interested in this topic. They also have a really tremendous toolkit that's actually a 2-day training that you can just read through and think about for free for talking about trauma in individuals with IDD. I just can't speak highly enough about the work they do. They have great research, great papers, great tips for providers, caregivers, just a really fabulous resource. All right, enough about that. So they talk about a traumatic event as a frightening, dangerous, or violent event that poses a threat to a child's life or bodily integrity. Witnessing a traumatic event that threatens life or physical security of a loved one can also be traumatic. So it's interesting because it's a fairly broad and also narrow definition at the same time, right? And I think this is actually a really important point. Trauma is subjective. What's traumatic and overwhelming for one person may be very manageable for another person. And what's really at the core of thinking about this is how a person perceives and reacts to a potentially traumatic event. That's really at the core of diagnosing and accurately treating their symptoms. We do have pretty standard trauma interventions, and they should always be accommodating of what a person specifically needs. So later on, we'll talk about things like relaxation skills as being a core of treatment. If you come into my office and you've already got some pretty solid relaxation skills, I am not going to spend a lot of time on that with you. You don't need me to do that for you. So one of the other things that I want to point out is that we don't talk a lot. I think my presentation tonight talks a lot about abuse and neglect as forms of trauma, because those are the ones that we think about a lot. But I also want to think about how attachment and separation can be a form of trauma as well. So I have worked with a fair number of systems-involved kids, so kids who move from foster home to foster home, who are in and out of court, and that's potentially traumatic, right? One of the best safeguards we have against the development of trauma symptoms is a safe and loving relationship. So if you are someone that hasn't had the opportunity to have that consistently in your life, or you're not sure how long it's going to last, that's going to impact your symptoms, but it's also going to be potentially a traumatic thing for you to work through, right? So I do just want to acknowledge that attachment and its development is a form of trauma for some people. Okay. You can't really give a presentation on trauma without talking about the Adverse Childhood Experiences study. This is really the study that I tend to think about as bringing trauma to the forefront. So we used to talk about trauma in the context of veterans returning from war. We talked about shell shock and then eventually PTSD. And we talked about things like rape victims, right? And there was kind of this idea that trauma was something that happened to other people, right? Or it happened to certain populations. And really, this was kind of a big turning point in that idea. So what the ACEs study did was it surveyed thousands of Americans who were in actually pretty high functioning situations. They had consistent insurance coverage, they were visiting their primary care practitioner, they were reasonably stable, right? And what we found was they asked people, they developed a set of questions for what would qualify as an adverse childhood experience. I am not going to put up on the board what those are, because every time I do that, everybody checks out to see how many of those boxes they check off, right? It's not actually particularly helpful to do that. I will give you just a general idea though. So we talk about physical, emotional, or sexual abuse as being an adverse childhood experience, physical or emotional neglect. And I think actually we don't talk a lot about emotional neglect as being a really serious issue. But how people relate to you and how they connect with you can be a tremendously adverse experience. We also talk about in the ACEs study household dysfunction. So parental mental illness, domestic violence, divorce, having an incarcerated relative, and substance abuse are kind of the core things that they were looking at. And what they found was really fascinating. So what they found was a little more than a third of people said by age 18, none of those things had occurred in their lives, right? That's great. We have a third of the population who's saying that this has not been an issue for them. What I find far more fascinating is that we have 2/3 of the population who are saying that this has absolutely been an experience in their life. And what's so fascinating about that is that that really turns that idea that trauma is a thing that happens to other people on its head. What it really points out is that adversity is a thing that happens to most of us. So just looking at the statistics real quickly, about a quarter of people said that they had had one adverse experience. About 16% said that they had had two. 9.5% said that they had three, and about 12.5% said that they had had 4 or more of those adverse experiences. So gosh, when you really look at it, how powerful is it to simply acknowledge that if you've had something like this happen to you, most of the other people in a room with you have had them too. They may have been different experiences than you, but you are not alone in what you've experienced. And this is one of the really important ideas about trauma. It's so isolating, right? It tells us we're the only one that this happened to. It's because I'm dirty, I'm alone. It's too unbearable for me to tell anyone. I would be so ashamed if people knew. And what we're really finding is if you share your story in a comfortable and safe place, the most likely response is me too, right? And that's a pretty important thing. So when the ACEs study came out, like I said, this really changed the concept of trauma, and it got people thinking more and more about what this would mean for our population. The other portion of the ACEs study that they wanted to know about was what was the long-term trajectory for people who had adverse childhood experiences. What they found was the more ACEs you experienced, the more likely you were to suffer from a variety of difficulties later in your life. So they talked about cardiovascular health as being impacted for a variety of reasons, right? We know when you're stressed, it's harder for your body to maintain its health, right? If you're stressed, you may resort to coping strategies like smoking, right? Which could have an impact on you. We also found that as ACEs increased, sorry, I said we found, I wasn't on this study, I was like 10 when this study came out. I'm not like that great, but I'm like real pro ACEs. So what they also found was that adverse experiences also contributed to psychosocial factors, like whether you were stably housed, whether you had a job that was consistent and paying enough for you to survive, whether you needed to resort to using social services on a frequent basis. And they found that those things were really correlated with the number of adversities that you faced as a child. Right? And it makes a lot of sense. I can see some of you thinking about what this might mean for you. And I want to challenge you real quick to think about that every person is different, and one of the best things about trauma is that we know what to do about it, right? We have really excellent treatments that have shown really positive outcomes. So I don't want this to be a moment where you start feeling like this is not something you can recover from, or this is why things have been so hard, right? This may explain part of your story, but adverse experiences are a chapter in your book. They're not the entire book, okay? I just really want to reinforce that.
Is there a more updated study? I mean, that's 22 years old.
It is 22 years old. So the question was, is there a more updated study? There have been follow-up studies to talk about specific prevalence in specific populations. And certainly this is, because this really kind of opened up the field in a unique way, there's just been a ton of research to come after it, to continue to find relations between adverse experiences and long-term consequences, but also prevalence. And we find that they stay relatively similar, although we're learning more and more about what they look like for different populations and why those might be risk factors for those populations. I want to talk about risk and protective factors for trauma-related symptoms. So one myth I want to dispel is that PTSD is the only diagnosis that comes from trauma. That's absolutely not true. We know that for a small percentage of people who experience a potentially traumatic event, they do develop symptoms that meet all of the diagnostic criteria for PTSD. That is the minority of people, though. What we find is that this can really relate to depression, anxiety, difficulty with attention, right? Sometimes we talk about how ADHD and trauma can be so difficult to pull apart. If you're struggling to think about whether you're safe at home, it's going to be really hard for you to learn math, right? It's not a value that you have because other things are getting in the way. So that being said, I want to just talk a little bit about potential risk factors. So we know that interpersonal trauma, so interpersonal violence, sexual assault, witnessing domestic violence between your parents, that is more likely to lead to post-traumatic stress symptoms than are some non-interpersonal forms of trauma, like being in a natural disaster, right? And I think it makes sense, right, that if the people we trust or that we're supposed to trust or the people that are supposed to make our world feel safe don't do that for us, that's pretty ground shaking, right? It's hard to recover from that effectively. There is a conversation about chronic exposure to adversity in childhood. So, and Harvard and Jack Shonkoff do a lot of work on this, and it's really fascinating to think about that. Yes, we know, right, like I said, if you have 4 ACEs, you are more likely to experience stronger symptoms than someone with 1, probably. But I want to be careful too about that this is kind of bi-directional. So yes, having a lot of childhood adversity may lead to trauma symptoms, and trauma symptoms may impact your relationship with the environment and contribute to adversity. So just as an example, if you, I can't tell you the number of kids I have seen who have witnessed domestic violence at home, and they go to school and they're violent and aggressive at school, right? They're reenacting what they see at home. When you're violent and aggressive at school, some of the consequences can be physical restraint and seclusion, right, which can be potentially traumatic. It can be difficult to learn. Teachers might get irritated with you, and that's an unstable relationship that most kids really benefit from, right, the relationship with a teacher. So this is really bi-directional. Adversity can impact symptoms, and symptoms can impact your risk of adversity. Does that sound okay to everybody? Okay, I just want to make sure that that's clear. We talk about polyvictimization, so that's being victimized more than one time. So we know that there are some situations where you being a victim of assault or abuse can contribute to being a victim again for a couple of different reasons. So one is just as the example I just brought out, right, of if you witness domestic violence at home and you go to school and you're very violent and aggressive, it is likely that may have a consequence with how people interact with you, right? You may be more bullied because of your behavior, and that can be a form of victimization, right? So they can contribute to each other. We also know that in some situations, trauma can really impact how we see and interact with the world. So if you've been a victim of sexual assault, you may experience the world as being totally unsafe, right? And your judgment about safe and unsafe situations may be really different from what we might expect from someone who hasn't experienced something traumatic like that. So those can lead to being, they can lead to polyvictimization, and the reality is too that sometimes our circumstances contribute to us being a victim, right? If you grow up in a household where financial stability is not there, and you're not not sure what's going to happen day to day, you may find yourself in situations making decisions about money that people who are stably housed and financially secure aren't making, right? I've worked with kiddos who were really doing the very best that they could, and based on their family circumstances and just where they happened to live, they were high recruits for gang involvement, right? That's another way that we end up potentially being victimized, right? That's a really scary path to go down. Thought suppression post-trauma. So let me tell you about what thought suppression is. I want everybody to not think about the Duracell bunny. Just don't think about it. If you think about it, stop thinking about it. Are you thinking about it? Don't think about it. Stop. No Duracell bunnies. Stop. Okay, so just show of hands. Sorry, Facebook, I can't see you. Did anybody's thoughts about the Duracell bunny go down? No, I didn't think so. I'm really glad that worked out for me. Did anybody start to think more about the Duracell bunny because I kept mentioning it and you were trying not to think about it? Yeah, perfect, good, this worked really well. So this is thought suppression, right? When something traumatic happens, we try not to think about it. We push it down. We think of other things to think about. And we always talk about trauma as being like a beach ball, right? If you go to the beach and you take a beach ball and you try and shove it under the water, what's it going to do? It's going to pop right up, right? And this is the same idea. The more you try not to think about something, the more difficult it is not to think about it, and the more it pops up in other places, right? And this happens with trauma, right? If you're trying not to think about what happened, it's going to start popping in at work, it's going to start popping in at home, it's going to start popping in your relationships. And so we have good evidence that that strategy of trying not to think about it is actually related to an increase in post-traumatic stress symptoms. Unhelpful or inaccurate beliefs post-trauma. So we call these maladaptive cognitions. They're thoughts and beliefs that are not helpful to you. So a lot of times we talk about self-blame as being related to trauma. It's my fault because of what I was wearing. I should have told him to stop. I should have kept my mom safe, right? These are all inaccurate beliefs. And when those are at play for you, and let's be honest, right? We all have inaccurate beliefs about the world, right? I have an inaccurate belief that if I just tried harder, I could be Lady Gaga, right? It's not going to happen for me for a multitude of reasons. The most important one is that I can't sing. So, but that's an inaccurate belief, right? And if I really commit to that belief, I can make everything fit with that belief, right? I got in trouble at work today for singing and dancing down the hallways. They just don't understand my artistic talent. It's really because they're threatened by me, right? It's not because that's just not what you do at work, unless you work somewhere cool. Children's is really cool, right? But I can make everything around me make that make sense, right? And unless you have somebody who's willing to gently and delicately pull that apart with you and examine the reality and why you might be having those beliefs, it's going to be awfully hard to recover from them. And that's what we find with trauma survivors, is that they tend to try and make things make sense, right? Because we're all looking for order and structure in our lives, especially amidst the chaos of a traumatic experience. When we think about folks with autism and intellectual disabilities, this is really important to think about, right? We talk about that social insight piece and knowing why people do the things they do, and especially how that comes into play when we're talking about people who do things that we can never explain, right? We can never explain why sexual abuse happens, right? We can talk about why someone might have done it, but I can't make that make sense to you on a logical level that makes it acceptable, right? Because it's unacceptable. And so when we think about folks with autism, thinking about how their perceptions of the world around them and their interactions with the world may really be impacting their understanding of what happened to them, right? There's a lot of good research to talk about the prevalence of bullying and being ostracized for people with autism. And that's already hard enough on its own. And actually, there's some really interesting studies that have shown that, or have found that for people with autism, or for children with autism, being exposed to bullying and being socially ostracized was more traumatic for them than being involved in like a natural disaster or living in a war zone, right? Which is the opposite of what we find with the typically developing population. And this is an important thing to think about as a provider as well, that sometimes I think we make the assumption that because people with autism make social connections in different ways than what typically developing kids might do, we assume that it's not a value for them, right? That being socially connected is not a value, and that's absolutely not true. But when we talk about diagnostically for trauma, thinking about if you have a really unhappy and scary connection with the world because of what you've experienced, we need to take that into account when we're talking about social avoidance too, right? Is it really that you're not interested in social interactions, or is it that you've had some really negative ones and now it's kind of off-putting to try again, right? We also know that for people with limited social support and who withdraw from the world around them, their post-traumatic symptoms are more significant than people who are well connected. And again, this is one of those moments where this is really subjective, right? What well connected is for me is different than what it is for Jen, right? I need 2 strong friendships to feel pretty well connected. I need to know that if I send a text, someone's gonna respond at some point, and hopefully they're gonna send me like a funny meme, because that's gonna get me feeling better, right? I have a friend who has like 50 bazillion friends, which I find overwhelming just thinking about, but for her, that's really what she needs to feel socially connected and successful. Neither one of us is wrong, we're just different, right? So just remembering, especially as providers, that what social connectedness and support looks like is different for different people. Okay, so talking about the prevalence of trauma, some of the best research we have on trauma is really about prevalence of being a victim of abuse. We don't have as much good data on some of those softer kinds of trauma, and I use softer kind of, I don't know what to make of that, but when we talk about bullying and what impact that has and how many kids are bullied, there is some good data out there, but I think it's not as strong as when we have CPS reports that we can kind of correlate. So just putting that out there. So we've already talked about the prevalence of ACEs, and we know that by age 16, most people have experienced at least one. We know too that about 9.1 children out of 1,000 are a victim of abuse or neglect. I'm going to caution you about that because we know that there are many populations that don't report, right? Or who are inaccurately investigated for substantiating a claim, right? So some of the research that I'll talk about tonight talks about child abuse or neglect reports versus child and abuse neglect substantiated cases. And that's where people who have investigated, like CPS, have found that there is credible evidence that something has happened, right? Which is a hard bar to reach. So I do just want to talk about the fact that while we think it's about 9.1 per 1,000, that's probably a low estimate because we know that there are a lot of kids out there who no one ever knows what happens to them, right? So let's talk about it in children with developmental disabilities. So we know statistically about 1 in 6 children ages 3 to 17 meets criteria for developmental disability. Depending on different studies, we have some good evidence that those same children comprise about 10% to 25% of our population of kids with IDD have been the victim of substantiated abuse claims, right? That means someone found enough evidence to say, yes, this really happened, right? And the studies really vary on this. There are some studies out there who will say the rate of trauma or traumatic experiences in people with IDD is 90%, right? The reality is, as hard as it is to accurately identify this in the typically developing population, it's more difficult in the IDD population for a couple of reasons, right? One of the big ones is we frequently misunderstand cues that kids are giving us as symptoms. And I'm going to talk more about that later. Another is, by definition, this is a population that likely has some communication deficits. And that really impacts how we understand and listen to them. Right? So just knowing that these figures may not be totally accurate, but they are the best that we have right now. They're the best we can go on with the evidence we have. So there's a really excellent study that just came out that I think is from Kentucky. Shoot, I don't remember what state. But it was looking at the rate of substantiated reports of abuse or neglect in children with developmental disabilities. So here's what they found. About 10% of children who were only diagnosed with ASD had substantiated reports of abuse or neglect. About 16.5% of people with ASD and ID had substantiated reports. and about 25% had ID only and had substantiated reports. I just want you to know that 3 people out of 10 people is 33%. That's not 25%. I put a handmade little character on there so that it would only be half of this person, and it's gone. So I do know my math. I'm not great at it, but I do know it. Okay, compare this with our rate of 8.8% of substantiated reports in typically developing populations, right? So we know it's already higher. And again, this is substantiated reports, not total number of reports made. So just diving in a little deeper with this, in terms of sexual abuse, the ASD and ID together populations and ID only groups were more likely to have reports compared to typically developing controls, whereas the ID only group was more likely to have substantiated reports. So there is some conversation in the literature right now about whether ASD may actually be a protective factor, but this is really, really varied depending on reports. So there are some studies that have found that you are less likely to have a substantiated report if you have autism only, and there are some studies that have found that that was not the case at all. So I don't think we have a good answer about that one right now. In terms of physical abuse, all of these groups were more likely to have a substantiated report than typically developing controls. All of the groups were more likely to have a report, but the ID only group was most likely to have a substantiated report. For emotional abuse, the ASD only and ID only groups were more likely to have a report, and the ID only group was the most likely to have a substantiated report. So there's a trend here, right? And the data shows us this. The ID only population is most likely to have a substantiated report for physical abuse, sexual abuse, and neglect, right? And emotional abuse. But we're seeing higher prevalence among all of these populations. Yeah.
Is it understood whether that's because the actual rate of occurrence is lower or because something about it makes it harder to substantiate a report?
So the question was, is this because, sorry, my working memory is terrible. Okay, is this because there were actually fewer incidences of abuse among these other populations, or because
it's harder to substantiate for some reason.
Because it's harder to substantiate for some reason? I don't know that we actually really know the answer to that question. And again, I think this leads back to that question about, like, is ASD a risk factor or a protective factor? The data tells very different stories about that. I do kind of sometimes wonder about in our ID only population if one of the potential risk factors is having more people involved in your care, right? That's more people to try and control their behavior, the provider's behavior, not the child's behavior. And whether that is also potentially, whether that's a risk factor for them in terms of more abuse and more eyes on what might be happening, so more reports being made. I don't really have a good answer to that one. I think that's a great question. Yeah. So let's talk about what could potentially contribute to heightened rates of abuse. So one of the biggest ones that we know is true for typically developing populations and individuals with IDD is the socioeconomic stress in their families, right? It's really hard to stay calm when you're not sure where your next meal is coming from. We know that parents of people with IDD have a higher stress level. So there's a study that found that about 42% of parents reported clinically significant parenting stress when they were parents of kids with a developmental disability, and that is markedly lower than the rate for typically developing families and children. We can also talk about that when you are managing your child's care, and that involves multiple appointments, meetings, IEP meetings, engagement in therapies, that also limits your access to work, right? It's really hard to work in that environment. And that can lead to socioeconomic stress, right? And that's a big factor that we find. Also, I mentioned this before, but communication delays and social delays that can come with these diagnoses, right? So I have a friend who has a child with autism whose communication was very delayed. And he qualified for special education transportation starting when he was 3. And she made the decision that until he could accurately relay information about his day to her, she was not comfortable with him riding the bus because she didn't know what was happening on the bus. Before a school district sues me for saying that, I just want to be really clear. There are plenty of situations that can be potentially risky like that one, and that 99% of the time are totally fine, right? I'm not telling you to stop letting people ride the bus. I'm saying that that's something that she had to think about, right? Was that if you are not able to tell me how you're feeling and what happened to some degree today, she was not comfortable putting him in a situation where he was unsupervised with one adult. Right? Also talking about that social delays piece. So in some of the research, there is a conversation about potentially socially naive behavior on the part of people with IDD, right? So trusting situations that might not be trustworthy, missing social cues that might really kind of bring the hair on the back of some of our necks up. That's a real issue, and can really lead to some potentially stressful situations, and again kind of contributes back to that idea of unhelpful thoughts and beliefs, right? If only I had known that he was not going to be safe, I would have done something different, right? So thinking about how that might be impacting the experience and the decisions that some of our kids are making. We also talk about the prevalence of challenging behaviors in this population, right? And I'm a firm believer that all behavior is communication in one way or another. We act the way we act to get a need met the very best that we can because we don't know what else to do to get that need met. Right? And the fact remains that challenging behaviors can elicit really unsafe responses from people around us, right? So we know that, like I said before, the rate of restraint and seclusion can be higher in this population, and that is true for kids with emotional and behavioral disorders separate from developmental disabilities too. And we know that that can be a really scary experience for a kid. And while school districts are really trying to improve their use and limit the use of restraint and seclusion, we also know that it's not a uniform plan that experience is processed with a kid after it happens to help them understand the situation and the outcomes, and to make sure that there's a plan in place to rebuild that trusting relationship with teachers and TAs that we really need kids to have in school, and that can be really violated by restraint and seclusion, but also that kids have the opportunity to learn a new skill to try and avoid that situation again. I want to be clear, I'm not blaming kids for the behavior that they show, but I'm saying if you are really, really frustrated in class and you can't ask the question in a way that makes teachers understand what you need, I understand why you might start screaming and yelling and accidentally hit someone, right? So we really need to be talking about challenging behaviors and reinforcing replacement behaviors for that to help kids learn new skills if we want them to progress, and if we want the risk of them having an unsafe physical situation with a teacher or school staff, we kind of got to put that part in place. I think it's also really important to talk about parental grief at this point, right? We talk about that for parents and caregivers, no one wants to watch their child struggle, right? That is the most precious person in the world to you. And I don't know any caregiver that doesn't want to see their child succeed in whatever way is going to be most valuable to them, right? And if you have a preconditioned idea of what your child was going to look like, what they were going to do, how they were going to act, were they going to play basketball just like you did, and those things don't happen the way you expect, we know that grief is part of that process, right? There's no shame in that. There's nothing wrong with who your child is. It's just not what you expected. And there's a whole work of coping that goes into managing that. And we know grief brings out upsetting emotions and might contribute to the way that you interact with the people around you, right? This is true when we talk about child trauma as well. I'm not really touching on grief and bereavement tonight, but that is certainly a traumatic event, right? Losing someone, whether they are literally gone or losing the person you thought you were going to have in life, is traumatic, right? And as much as we know that children, their behavior might change based on a traumatic experience, it's reasonable to expect that caregivers have a change in behavior and a change in their ability to regulate their emotion based on that situation, right? So it's possible that we have parents or caregivers who are under a tremendous amount of stress financially. They're expected to come to 50 different appointments every week, and maybe the message they get from a provider is, I was really expecting you and you weren't here. I'm kind of disappointed in you, right? That's an awfully difficult thing to hear. Even if we don't say those words, if I do something to accidentally communicate that to you, I know you're going to take that home, right? We have parents that feel judged by other parents or caregivers or providers or teachers who don't understand what it's like to be in your shoes. We have caregivers who aren't able to pursue the career that they might have wanted to pursue, or they've had a change in what they're doing. That's all very, very stressful, right? And we know that that kind of stress can really lead to some big behaviors from caregivers that otherwise, if all things were right and you had all the support you needed, you might not ever make that choice. We also talk about that the fact that folks with IDD are typically involved in multiple systems, right? I have families who come to see me they're in a medical clinic here at Children's. They're interacting with social work here at Children's. They come see me for therapy. They have to talk to DVR about employment options. They have to negotiate with the school and decide what to do about an IEP. Maybe they're consulting with an attorney about something. All this to say, that's a lot of time that kids are spending in multiple different systems of care, right? And similarly, we know while being socially connected can be a very important strength in preventing post-traumatic stress, it also increases the number of people that are interacting with you on a daily basis and may potentially increase the risk of being exposed to abuse. Does that make sense, that connection that I'm making? Okay. We also talk about this dependence on others piece, right? If adaptive skills are still an area where you're developing, you may depend on people to do things for you that make you more vulnerable, right? It may also mean that you don't have the power to say no and walk away in a situation because you have someone who's supposed to be by your side all the time, right? And so thinking about what that kind of involvement and dependence on other people means from multiple different angles, right? It may make you more exposed to potential abuse. It may also impact your perception of the world and your place in it, right? We all want to be independent in certain ways. And when we talk again about that kind of that maladaptive cognition, those unhelpful beliefs, what does it mean if you're abused by a caretaker and you need a caretaker to help you function on a day-to-day basis? Right? What does that mean about you? What does that mean about the world? What does that mean about your safety? So it all kind of plays together, okay? let's talk about kind of the core components of trauma symptoms. Before we do that, can we all just take a deep breath real quick? Okay, I don't know about anybody else, but like my shoulders are like up here. I don't want to be Lady Gaga anymore. This is too much pressure for me. I'll let her have it. So when we talk about trauma and diagnosing trauma-related stress in children and adults, we talk about some core hallmarks that we're looking for. So we talk about intrusion as being a big component of this. So when I talk about intrusion, I'm talking about memories or thoughts that are happening to you that you don't want to have happen. Okay, so we talk about unwanted memories of things popping into your head when you don't want them to, when you're not ready for them to. In kids, we talk a lot about nightmares. And in kids, it's really interesting. A lot of times kids will report, yeah, I have nightmares, but not about what happened. And I'm not actually totally interested in the content of your nightmares. I want to know how much intrusion are you experiencing. If 3 out of 5 nights of the week you go to bed and you wake up in the middle of the night because of a nightmare, that's not what I expect to hear from a kid who's not reporting any trauma symptoms, right? So I really am going to think about that regardless of what the content of your nightmare was. In kids, we also talk about an intrusive symptom being reenactment in play. So I've worked with kids who had very minimal language skills, and every time we got together to play, they told me that there was a car crash and then the police came. Right? While the kind of the theme of police, ambulance, fire department is actually really typical in play, if it's continuing to happen in your play and we're not able to successfully resolve that story, right? So what I want to know from you is, if the police came, then what happened? If you tell me, well, they fixed everything and everybody was okay and they went home, I might think differently about what you're bringing into your play, as opposed to if you tell me they beat everybody up and they arrested my mom. I'm going to think kind of more strongly about that. Although I give credence to any kind of reenactment that's happening in play, and frequently it's not that obvious, right? When I work with kids with very limited verbal skills, sometimes what I see is that they build and build and build, and then they crash everything down, and it's kind of like nothing is safe in their play, right? And certainly this really depends on developmental level, but when I think about kids and their play and potential reenactment, I'm looking for themes that continue to come up. So if you come to my office and do that once, I'm not going to make a decision about that. I really want to know how often is that happening. When we talk about intrusion, we also talk about being very distressed when you're reminded about the trauma. So if you can't drive by the place where something happened without getting really distressed and tearful, and maybe you start to shake, I'm going to talk about intrusive symptoms for you, right? And one of the other ones that we talk about in intrusion is this idea of dissociation. How many folks have heard about dissociation? Okay. I want to be clear that dissociation is this idea that we kind of check out for a little while, right? And sometimes it happens because our brains just simply can't handle any more of what's being talked about, what we're being reminded about. And sometimes it happens because we're all human. It happens to us all the time. When I drive to work, there's a solid amount of time that I'm not sure how I got from the Starbucks drive-thru to the stoplight on 55th, but I know I made it, right? Not because I was being upset and thinking about something that I didn't want to think about. It's because I just kind of spaced out. I still drove the car. I was okay, right? Maybe don't tell my insurance company that I'm divulging this to you, but this is really normal. We do it when we go to meetings and you kind of don't remember what somebody said, or you get called on in class and you're not sure what was going on. Dissociation is not that abnormal. when we talk about it being an intrusive symptom of trauma, we're really talking about when it's happening to a marked degree and we can pinpoint some of the triggers that might be bringing it on, right? So I certainly know when I do trauma work with folks, if I bring up that they have a court day coming up and you kind of check out for a minute and then you come back and you tell me, I'm going skating with my friends later, I know that I may have just hit on something that is too scary for you to talk about right now. And that brings me to this idea of avoidance too. So avoidance is a huge part of trauma. It's also a huge part of anxiety in general, right? Anxiety is the messages that we send ourselves about why we shouldn't do something. And when it becomes a problem is when we're doing it too much, to an unhelpful level, right? I hate flying on planes. I would do anything to avoid it. And there was a point in my life where I chose to rent a car and drive 500 miles to avoid having to get on a plane. That was unhelpful, right? That's over avoidance, okay? But this happens to all of us for different things, right? And when we talk about avoidance, we're really talking in terms of trauma, we're talking about avoidance of people, situations, places, reminders, activities that in whatever way relate to the traumatic event. And I want to bring this up within the context of dissociation too, right? In therapy, my job is to help you start to feel more and more comfortable talking about or thinking about those very upsetting experiences, right? So I would not be doing a good job as your therapist if you started to dissociate and I decided I was never going to bring that topic up again. I would be feeding into your avoidance. And we know that avoidance is where that beach ball thing comes in, right? If we don't face it and start to talk about it and get more comfortable with it, it's going to pop up in ugly places that we don't expect it to pop up. I talked a little bit about changes in cognition, right? Those beliefs about the world isn't a safe place. I have a client who told me once, "Don't ever come to my city. There is no one nice here." That's a maladaptive cognition, right? It is not statistically possible that everyone in your town is an awful human being, but right now it feels that way. That change in cognition piece also really relates to your self-blame. It's my fault that this happened. I shouldn't have asked him to go to the store. He wouldn't have been in that car accident, right? And the last piece is we talk about alterations in arousal. And I think this is an incredibly important one when we talk about our IDD population, right? So we're really talking about a change in your behavior that is connected to, in terms of time, something traumatic that happened or potentially traumatic, right? So if you come in and tell me that that someone you care about was in a really horrible accident and they died, and then I find out that you were doing really well in school and being pretty successful, and lately you've decided that you're skipping your classes and you've gotten in 6 fights in the last 2 weeks, and you punched your mom in the face, that's an alteration in arousal, right? That's a change in behavior. And sometimes for our populations who can't use their words to tell us what's happening, this is a really key hallmark to pay attention to. Right? For a lot of kids for whom their verbal skills are not yet developed, we're really looking at those changes in behavior, and that can look like a couple of different things, right? So we might just see a broad expansion in their externalizing behaviors, the big behaviors that we see that we can observe: hitting, kicking, biting, scratching, screaming, right? We might see a change in their rate of self-harm, self-injurious behavior. We also talk about hypervigilance. So hypervigilance is this idea that you always have to be on edge. I have worked with kids who I can't wear my badge when I meet with them because they are so used to Child Protective Services workers coming in and they associate a badge with something happening that I leave my badge in my bag, right? that's hypervigilance. It makes sense based on their experience, right? And that's not really serving them. We also talk about an exaggerated startle response. So these are kids who they hear something down the hallway and they're up, and they're standing up, and they're looking around, right? I worked with a kid a really long time ago who we were sitting in my office and we're having a really nice session, and someone walked by and bumped the handle of my door, and he jumped up, and this was a little guy, right? He jumped up and screamed every curse word that I have ever heard, plus like 6 more that I learned from him, and said, "I know that's the MF and cops out there," right? That's hypervigilance and an exaggerated startle response, right? That's disproportionate to that situation. And for him, that was his reality right then, right? So again, some of those physical symptoms, right, like the hyperarousal, changes in behavior, exaggerated startle response, those are really things to be thinking about for folks with IDD, because those are some of the best communication tools, right? Yeah.
So then, how do you piece that out if you're working with someone with sensory processing challenges?
Mhm.
They can look very similar.
Yeah, so the question was, how do you differentiate that from sensory processing challenges? So I would really be thinking about baseline behavior and what I knew about a child before the thing that I suspect was traumatic for them happened. So a lot of times, in fact most times, I haven't met you before the traumatic thing happened, right? That's our connection. So I really rely on caregiver and other provider report to talk about what they've noticed before and after. Typically, and just this is something that I do and that might be helpful for providers, I tend to ask more about post-event behavior because I want to know what you've seen most recently before I ask you about pre-event behavior. And here's why. We all have a tendency to really want to make our point. You need me to see that your child is suffering. You need me to see that they need these services, right? And so if I ask you, what was their behavior like before this happened, and then what was it like after it happened, I think a lot of people are going to be naturally inclined to say, oh my God, it's so much worse now. Please, are you hearing how bad this is? Please help me, right? And you're not lying. You're saying what you believe, but also what you think I need to hear to believe you, right? So I want to know more about what have you seen lately, and then let's go back and talk about what you saw before. Does that make sense? Right. And I think that's true too for sensory processing issues, right? Especially we think about sensory processing concerns, and those can totally be trauma related too, right? So all of a sudden, if your abuser wore khakis every time, all of a sudden, if you start not being willing to engage with anyone who's wearing khakis, it might be really easy to assume you have a sensory issue with that fabric, right? And really that might actually be a trauma trigger for you or a reminder. So I do think they can totally go hand in hand, and I wouldn't discount either one for the other one.
Well, and new research is actually saying that sensory integration is a treatment for trauma, individuals that experience trauma.
Yeah, so let's actually, so sorry for people on Facebook, she said there's some new research that's talking about sensory integration as a trauma treatment. And let's talk about, oh, I'm not there yet. Okay, I'm just gonna, no, it's okay. Let's talk about that in a minute when I get to my slide, but I'm gonna talk about exposure as a treatment, right? And how those two can kind of go together. Okay. So I want to just kind of touch on some diagnostic considerations for specifically trauma symptoms within the IDD population. This is not an exhaustive list. These are some of the ones that I think are most important, okay? So thinking about that limited verbal communication and talking about behavior as a form of communication in this population, right? If your child is really struggling and this is a change, that's something I'm going to be really interested in, and I'm going to be less less focused on what they say and more focused on what they do, right? That being said, I do also think it's important to think about repetitive speech and what kind of speech is coming up, right? So just like I said, right, I had a client who was really very limited verbally, but he always could act out someone hitting someone else, right? Or he always, in his play, had the cops in his play, right? To me, that's really indicative, and that was his form of communication. We talked about increased aggression as being a potential sign. We also talk about hyperactivity, right? That's that kind of increased agitation that we're talking about. And this is why it is so tricky to pull apart ADHD and PTSD or trauma-related symptoms. They can look so similar, right? Like we were talking about, if you're not sure if you're safe at home, I doubt you're going to pay strong attention in math class. You are more worried about other things, right? If you're constantly on guard and you're not sure if the world is safe, you might look pretty hyperactive to people. This is true for typically developing kids, but I think it's especially true for the IDD population, is that regression in development, right? When the world becomes very scary and you're not sure how to incorporate that into your understanding of the world, it is very common to see a regression in development. So signs I'm looking for are bedwetting, difficulty doing skills that you used to be able to do independently, or relying more on people to help you. When I've had parents come in and say, I know he can do this on his own, he's been doing it for a really long time, and all of a sudden he's not willing to do it on his own. It may be that he's not willing to do it on his own. It may be that he lost the skills to do that temporarily, or it may be that he's seeking some extra comfort and asking for your help as a way to get it. Behavior that's developmentally incongruent. So I've seen kids develop like baby talk, right? Where they used to have a pretty typical voice, and now they talk like a baby. That bedwetting piece, right? There's kind of those hallmarks are things that I'm thinking about and looking for, especially in this population. Difficulty with peer relationships, so that can look a couple different ways. Like all of a sudden you're getting in fights with your friends and you didn't used to do that. One thing I find interesting is also that kind of increased rigidity, right? When the world is swirling around you, you are going to look for and make structure and control anywhere you can, right? So maybe all of a sudden the things that your friends did when they changed the rules in Uno, that used to be okay with you, and now you're really effing pissed off about it and you're going to flip a table, right? That's kind of what I'm thinking about. I also think about when kids kind of suddenly lose interest in peer relationships that they used to be interested in. To me, sometimes that's a sign that there's maybe some withdrawal from the world because maybe the world isn't a particularly safe place for you right now. Feelings of hopelessness, why bother trying, right? And delayed independence. So thinking about this as not only a symptom of post-traumatic stress, but also kind of a risk factor, right? It can be a symptom in the sense that it doesn't feel safe to try the things that you were doing to take steps towards independence anymore. And also, like I said, maybe you're looking for some extra comfort, and this is one of the ways you know how to get it. If I stop going to the bathroom on my own, you have to help me, right? Remember, all behavior is communication. One thing I want to say for providers is, I know I'm giving you a list here, and it's never this easy to figure out, right? I will say for trauma, especially within this population, I'm really never comfortable, well, rarely comfortable making a decision like this in one visit. I really need to know what's going on at school, what's been going on at home, what are caregivers noticing, what are other people noticing, what do you look like when you come in to see me, what's your play look like, and I want to know again about themes, right? So I know that I'm kind of preaching an ideal situation for providers, right, where you have time to make these decisions, but I would really encourage you, if you're thinking about it and you're not sure, this is the time to schedule a second appointment. Please do that. Okay, a couple myths about trauma treatment, and this comes from the NCTSN toolkit for trauma with IDD. A couple of these, and this is really for providers. I want you to think about this. There's a myth that children with IDD cannot engage in treatment. Well, gosh, I guess if cognitive behavior therapy is developmentally not appropriate for you, and I decide that that means you can't engage in treatment, I might as well say that people with diabetes can't really get treatment if they get a candy bar sometimes, right? It's not accurate. We can all benefit from treatment. It's about your ability to kind of change your expectations and your treatment style to fit that population, right? Again, standard mental health treatment is ineffective for children with IDD. Kind of the gold standard of trauma treatment is trauma-focused cognitive behavior therapy. I do it a lot with kids with autism. You can do it with kids with developmental disabilities. You can do it with kids with intellectual disabilities. It's gonna look different, right? And that's okay. That's okay. When I do treatment, I don't need to be right about how your treatment should go. I need to be right about listening to what you're saying and what's working and what's not working, and meeting you where you're at in terms of engaging you in treatment. Yeah.
I heard that there was going to be a larger study of TOCBT with children with autism. And do you know if those larger studies have come out or?
I haven't seen anything, but gosh, if you find it, I would love to see that.
Yeah, it was Judy Cohen.
Uh-huh.
Said that the NCTSN was going to trial out some studies. This was a few years ago.
Yeah, that wouldn't surprise me if they do that, because gosh, it's certainly needed, if for no other reason than to convince providers that you can do this work with kids with autism and kids with developmental disabilities in general. Thanks, I'll be on the lookout for that for sure. Another myth, behavior modification is the only option, right? You can change someone's behavior. If you don't really get at the root cause, you're really not serving them the way they need to be served, right? I will tell you, if you come in for trauma treatment with your kid and they are wildly out of control, we are not going to jump into trauma work before we get that behavior under control, right? For one core reason, they need to have reliable structure in place, and structure is one of the first things that goes out of the place when trauma happens, right? For a couple different reasons. One is caregivers feel bad and they let things slide. Oh my gosh, I can't believe that happened to you. Okay, yeah, you can have a second Pop-Tart today, right? For another, because when something traumatic happens, there's going to be a change, right? It's a moment of change. Your emotions change, your behavior changes, people's reaction to you changes. Suddenly you have to go to an appointment that you didn't know you were going to have to go to anymore, right? That's all a change. And I still need you as a caregiver to work with me on getting that behavior managed so that we can move on to working on things like emotion regulation skills, right? I can't teach your child how to calm themselves down when they're feeling anxious if they're so aggressive all the time, right? It's not an effective intervention at that point. There's a myth that youth with intellectual disabilities do not experience trauma. I think I've done a pretty good job laying out today that there's lots of evidence that that's just patently false, right? Challenging behavior is always best explained by an intellectual disability. Not true, right? We know behavior follows experiences, right? That's one of the hallmarks of post-traumatic stress is a change in your behavior. So that one's just not true. Children with IDD are protected from trauma because of their developmental age. They don't remember. I don't know how many people with IDD we'd have to ask to find out that that's false, but I don't really need to ask anybody. I know that that's not true, right? People remember things. They remember it differently. Maybe they remember it somatically. Right? I have kids that have experienced very early childhood trauma that they don't remember, but their bodies remember. There's a great book called The Body Keeps the Score, and it's all about kind of what our bodies do to react and to try and maintain our comfort in uncomfortable situations. The last myth, and the most important, I think, to me, is practitioners must have extensive experience treating people with IDD. Nope, I don't think that that's true. I think what you do have to have extensive experience in is being flexible with your treatment and knowing that treatment should be tailored to the individual regardless of if they have a developmental disability or not. That's just good therapy. Just real briefly, I want to talk about core concepts in treatment. So I really start out with education. So I want caregivers to know about trauma, how often it happens, and what common symptoms are. And I want kids to know that too, to the level that it's appropriate for them, right? I will sit down with kids and look at national websites about the prevalence of sexual abuse. I want them to know that they're not the only one. We also work on relaxation skills. So these are just general skills that you practice all the time that I need you to have muscle memory for when those situations happen, when you become hyper aroused. I need you to know how to do that relaxation skill off the top of your head. We talk about addressing mood and behavior. So we're going to spend time working on, gosh, if you are feeling hopeless all the time, I really need to target that as part of your treatment before we start really jumping into how we're going to kind of unfold your trauma piece. Challenging those unhelpful beliefs and thoughts. I'm a really big fan of the responsibility pie chart, right? So I'll make a pie chart with kids and say, so what % of the responsibility for what happened do you have? And most of the time kids will say, well, I don't know, probably like 100%. And then I'll say, like, well, what % of responsibility does your abuser have? Well, none, because I should have told him to stop, right? My goal is to get you to a place where you don't have 100% of responsibility. In a dream, I want you to feel like you have 0, when that's accurate, right? So really challenging those beliefs. This is where that sensory piece comes in on exposure. So because avoidance is a core part of trauma, one of my big jobs as your therapist is to help expose you to thinking about and talking about what happened, right? For most people, a traumatic event, if it really impacts them, becomes the center of their lives. Everything is built around trying to navigate around that thing that happened. My job is, like I said, to make it a chapter in your story, not the entire story, right? So yeah, we're going to talk about what happened. Eventually, we're going to write it down in a whole complete narrative, if that's developmentally appropriate. I've had kids where we built the story in Legos, and that was okay. We're going to get used to thinking about and doing the things that are really aversive to you. So if your abuser smelled like peanut butter every time for whatever reason, you had better believe that we're probably going to spend some time looking at peanut butter, smelling peanut butter, and practicing those relaxation skills and those reminders about this is not your fault to help you cope with that. Because what I don't want is that you walk out of therapy and we think we're done and you get hit with a reminder and you don't have the skills to navigate it, right? And then we're going to talk about safety planning. So what kind of steps do we need to think about to try and help you in future potential experiences, right? That's a big part. And caregivers should really be part of this treatment the whole way through. You're not going to spend all the time in my office if that's not clinically appropriate, but I am going to check in with you and make sure that you know what we're working on and that you're working on homework when you're not with me. Just some quick steps for caregivers to think about safety planning and how to best support your child in talking about something or expressing it to you. So teach and respect body rights, right? The number of times that I see parents say, go give them a hug, just give them a hug, go, they're waiting, right? That's not body rights. You get to decide who you give a hug to. You get to decide who gives you a high five, and it's never wrong to say no, right? So I really encourage you to talk to your kids about what their rights are for their own body. Asking kids before you engage physically with them, can I give you a hug, right? That's really important. They should know that people have to ask them before they can do something, right? Developing adaptive independence as much as possible, right? So people are at all different stages, but working towards independent toileting is a huge one, right? One of the big things that we talked about at Children's Hospital Los Angeles, they have this really great program down there called Making Friends and Staying Safe, and it's all about abuse prevention. One of the things that they teach kids is this no-go tell, right? So if you can, if it feels safe, say no when someone does something you're not comfortable with. Then go and tell an adult that you trust. If they don't listen to you, go find another one and tell them. If they don't listen to you, go to the next one. And you keep telling until someone listens to you, right? One important thing about this is we can tell kids to say no, and we also have to acknowledge that sometimes it is so scary that saying no doesn't feel like an option, and that is okay. It's not your fault if you didn't say no. Your only job now is to tell someone so that you can get the help you need. Use accurate terminology. I know that sometimes talking about the correct names for body parts is uncomfortable, but if I can do it on this presentation in front of God knows how many people on Facebook, you can do it at home. Penis, vagina, breasts, right? Learn the language and be okay with saying it. If you're not comfortable saying it to your child, they're not comfortable saying it back to you. If your child comes home and says he took his stuff out, I don't know what that means, right? I don't know if that means he took his books out of his bag. I don't know if it means he took his penis out of his pants. The more language that you can give your children to talk about this accurately, the more likely they are to be able to accurately tell someone what happened, right? Try and reduce isolation, right? We talked about the more connected people are, the more helpful it is, and the more eyes that are on them. Right? Share as openly with medical and mental health providers as you can. I know that it is really scary to talk about things that have happened, and sometimes this is the same no-go tell principle, right? If one provider doesn't listen to you about your concern, please don't stop talking about it. It's our job to listen to you. I will say too, for providers, please ask these questions. Has anything really scary or upsetting happened to your child in your life that you can think of? When we don't ask the questions, we send the message that that's not an important part of their life, and we might be invalidating people, right? If I'm supposed to be asking you everything about you to figure out how to help you, and I don't ask you that piece, I basically sent the message that either it's not worth my time to talk to you about, or I just can't handle what you might tell me. And I always need my clients to know I can handle anything you tell me. And I'm not going to think it's scary or gross. And I'm not going to think you're scary or gross. So the more we can make that a regular part of our conversation, the better. That being said, also for providers, I'm really cautious about what I document in notes because I don't know where notes go, right? So I know that there was a push for a while to have primary care providers do ACEs questionnaires in their visits. And I'm actually really cautious about that because I don't know where that data is going. I don't know who else can see it. And if I ask you those questions and don't do anything about it, I haven't really helped you. Right? Last but not least, recognize your own unhelpful thoughts and beliefs as a caregiver, right? Well, awful stuff happened to me and I turned out fine. Okay. Well, maybe it's my fault and I'm really ashamed about that. Please try and recognize where your own beliefs and thoughts about yourself or your family or your child might be getting in the way of the decisions you make. Okay. I'm going to stop there and just see if there are questions that I can answer for folks. Oh, thanks.
Thank you, Molly. So I'm going to come around with Mike. So we're going to start with questions in the room, and then we'll go to Facebook folks.
Hi.
Hi.
I had been to a similar, I'm a TFCBT practitioner
Great,
and
yeah.
consultant, and I had been to a training a while ago, and they talked about how sometimes the trauma narrative component, if you're trying to do like a verbal narrative, can be more challenging because many folks with autism store memories differently in their brain.
Yeah.
And I didn't quite understand that part. So could you speak more to the storing of memories and retrieving of memories?
Yeah, sure. I don't have to repeat that, right, for Facebook? That's okay? Okay, perfect. Just want to make sense. One of the things that we do see in folks with autism is that sometimes their ability to recall sequential information may not be fully developed or intact the way we expect it to be. And so it may not be reasonable to expect that someone can give us a full narrative in order of what happened. So I tend to be a bit more flexible about that. I want to know the really, really hard pieces. That's my primary thing, right? And sometimes when I do narratives with people, they come out in a very disjointed order, and that's okay. It's my job to kind of try and wrangle it and make sure that it makes sense to the best of my ability, and to have that client agree that that's what they were trying to tell me. I also think it's totally fine to do narratives that are more picture oriented, right? So if you want to draw pictures instead of tell me in words what happened, as long as that's not feeding into your avoidance of talking about the situation, that's totally okay with me. Is that helpful to answering that question? Okay.
I'm a teacher, and I recently had a parent who brought up that she was concerned that her daughter wouldn't be able to express if something bad happened.
Yeah.
And do you have more resources that would be useful for parents to pass on about ways that they can support, especially children with autism with low verbal skills?
Yeah. So I will say Kennedy Krieger is a great resource. Krieger. They have a great center on trauma and do talk about it within the context of developmental disabilities. I also just think about encouraging parents that you know your child best. And so if you're worried about something, again, looking for those hallmarks, right? Big changes in behavior, disruption in sleep that really wasn't present before. That's kind of where you're most likely to notice a problem. And even if a kid has pretty low verbal skills, I'm still going to go over like body parts with them and body rights too. It may be that we're doing more acting out of body rights than we are about talking about it, but I'm still really interested in that muscle memory piece. Can you act out saying no so that you can use it in another point in time? Is that helpful? Okay, cool. Yeah.
I work with kids all the way through adults, and I feel like there's very minimal resources for adults on the spectrum, and I was just wondering if you have any good resources for those who might need it with trauma.
You know, the reality is I don't. That's really disappointing for me to say. I think therapeutically, providers who feel comfortable treating folks with a wide range of kind of verbal and developmental skills are probably the best bet for trying to seek out those same supports for adults. But the really sad truth is I don't have a lot of good resources for that.
It's really lacking in, I think, across the country, but in our community.
Yeah,
especially.
absolutely. I agree. Yeah. Okay. Facebook questions. Be gentle, Facebook.
We only have 3 so far. So
Okay,
we'll
great. Good.
start there.
Okay.
So the first question is from Katie Odom Davis, and her question is there a correlation between other risks or protective factors for abuse, neglect, and ASD or ID?
Is there a correlation between other risk factors?
Risk or protective factors for abuse or neglect and ASD or ID?
Okay, Katie, I think I understand your question, but bear with me if I'm not answering it. I'm leaving my email up so you can, if we need to clarify, you can always reach out. Yeah, I think we've talked about, right, that there are some risk factors that are kind of more unique to this population, so that developing independence that may be kind of delayed, the social insight piece and recognizing unsafe situations, knowing that you don't go up and introduce yourself to everyone in a room is a really important one. And again, that communication risk factor of being able to recount what happened or tell someone. I think those are certainly risk factors. When I think about potential protective factors, I do think, right, we may have a situation where people with autism might interpret a situation really differently than other people might. And so what might be really upsetting to some typically developing people might not kind of hit that same chord for people with autism. But again, I think that's really subjective. I will say, gosh, parents and caregivers of people with intellectual and developmental disabilities are some of the fiercest advocates and hardest working people that I've ever met. And that is certainly a protective factor, right? I don't know a lot of parents that, that give up the first time someone says no in this population, and that is hugely protective, for sure.
Thank you. So the next question is from Haley Johnson. If your child has abuse in the past, but is really acting up, becoming a teenager, asking about the past, can these trigger behaviors that he possibly wasn't able to understand when he was younger, maybe that he's understanding them now?
Yeah, totally. We talk about trauma as being, it changes with development, right? If I see you when you're 5 and we go through treatment, I may see you back when you're 9 or 10 because you may have a new understanding or a new perspective on what happened. And that is totally normal regardless of developmental disabilities, right? That, yeah, absolutely, that can totally happen.
So we have another question from Katie.
Hi, Katie.
How do you communicate about the % of responsibility when working with a child traumatized by restraint and seclusion following challenging behaviors at school?
Good question. So I would be thinking about one of the ideas that I use a lot with kids when they tell me that it's 100% their fault what happened. One of the lines I use is like, well, wait, but like they're an adult, so like weren't they much bigger than you? And like, how would you stop someone who's much bigger than you? My goal is to get them to say like, well, I can't because I was a kid, right? And that's kind of a turning point in being able to say like, well, then wait, if you couldn't have stopped them, like how could this be 100% your responsibility? And I could see how with restraint and seclusion, a kid might say, well, if I wasn't acting up, they wouldn't have done that. And my response to that might be, yeah, you're totally right. It could be that you were being pretty unsafe and that was scary for people around you. And maybe that's your responsibility in this part, but you don't get to control how other people act, right? So you can't be in charge of their decision to use restraint or seclusion. That just it can't be your responsibility.
Thank you. We have one more question from Jessica Frost. You brought up very blatant abuse trauma. For individuals with autism, are there instances that may be trauma to them that we may not traditionally view as trauma that would have been the same symptoms, or that would have the same symptoms?
Yeah. This is a really important point, right? Trauma is not what I think is traumatic for you, it's what is traumatic for you. So I talked about that bullying and being ostracized piece as being really highly correlated with post-traumatic stress symptoms in kids with autism, where it certainly is really upsetting and potentially traumatic for typically developing kids, but I think there's some good evidence that typically developing kids may have some more resiliency around that experience that kids with autism haven't yet developed. So yeah, I think it's totally possible. Yeah.
And we have one clarification from Katie, and this was for her first question.
Okay.
I'm going back to it. I'm not going to be able to get back to it. But Katie was talking about race, socioeconomic status, etc., and the likelihood of being diagnosed with autism versus just IDD.
Okay, I'm not totally sure. I'm sorry, Katie, I'm doing my best here. But I think there's already really good evidence to say, right, that kids of color are typically diagnosed at a later age. And that's kind of, I'm not sure exactly what, I'm sorry, Katie, I'm really trying here. But that we also know that kids from lower socioeconomic statuses have less access to diagnostic resources that could help clarify questions earlier on, right? So it may also be that when you're waiting for diagnosis from a provider, they may not have the ability the ability to also do cognitive testing, which could help clarify some of those ID questions, right? We may make assumptions about kids because we also know that communication style looks really different in different races, different cultures, different socioeconomic statuses. So what I may find is, as you not really engaging in my conversation, which I could mistake for communication delays, may be that it's actually really not comfortable for you to engage on that level with someone who's in a position of authority like I am as a doctor. So yeah, I think those can totally be confounding variables that could come into play. Good? Okay.
All right. Thanks, Molly.
Thanks,
this
everybody.
is a powerful and deep topic, and I know we've only scratched the surface of it, so thank you for your time and also for putting your email address up there for people to send you questions. So thanks so much.
Thanks, everybody.